Good afternoon, everyone. Thank you, Dr. Manuel, for the introduction. I'm Dr. Sara. My presentation to you today will be about immunization, which is basically shots to save patients' lives. This is the outline of my presentation. So, as we all know, as people age, they develop an increased susceptibility to many infections. And the world population is aging. With all the intervention we're doing to prolong people's life, they are living longer. By the year 2050, it's estimated that people who are 60 years or older, the population will reach closer to 2 billion. One of the goals of the WHO, they have a global strategy and action plan on aging and health. And one of the intervention is really, one of the goals is to plan and design interventions. You can't hear me. Really to ensure access and affordability of vaccines to adults in the second half of their lives. Immunization, as Dr. Emmanuel mentioned or alluded to earlier, is one of the most effective and cost-effective ways of prevention of disease and their complications. And it does represent the least expensive and easiest way to combat new epidemics, like we've seen in COVID. Success in immunization included worldwide eradication of smallpox and control of poliomyelitis with the hope of eradication. There has been elimination of indigenous measles and rubella transmission in the United States. And if you look at the studies, when they compare the year you introduce a vaccine, the mortality actually decreased by more than 99% compared to the prior year. Adult needs vaccination and as booster to either disease they were immunized to as kids or infected as kids. And also there are new vaccines developing. Now we'll shift to the burden of vaccine preventable diseases. I'll talk about a few of them. The burden of influenza basically varies from year to year with millions of cases yearly, with roughly more than 200 hospitalized, and of those, 75% occurs in adults. Invasive pneumococcal disease is almost an exclusive adult disease, with more than 80% of the cases happening in adults, and mortality is almost all amongst adults. Pertussis have seen a resurge in the US, and Hep B also remains a disease of affects a lot of adults. So general principle of immunization, the response to vaccine depends on few things: patient's age, their immune status, the vaccine, the type of vaccine you're using. In general, we have two types of vaccines: live attenuated and non-live vaccines. The live vaccines are mostly attenuated with the exception of adenovirus, and that's an oral vaccine licensed only in the US. Non-live vaccines include the recombinant vaccines, inactivated, and also in this category is the toxoids and the newer vaccines that use RNA or DNA. Spacing of vaccines, you have to try to stick to the scheduled immunization as much as possible. Also, one of the general principles, simultaneous co-administration of vaccines. For most of the licensed vaccines, co-administration is okay, and there is no problem with that, with few exceptions. If you are giving two live vaccines, they have to be given either in the same day, or it has to be separated by 1 month apart if you decide to wait. You cannot give a live vaccine and immunoglobulin in the same setting for obvious reasons of, response to the vaccine. And also, if you're giving the polysaccharides and adjuvanted pneumococcal vaccine, it cannot be given on the same day. There are few FDA-approved combination vaccines, and it's lookable information. Interchangeability: if you are using different vaccines from the same brand, you can probably just use don't have to change anything about the series timing or duration. But if for any reason you started with a brand and then you have to use another, continue the series with a vaccine from another brand, then you use the longest recommended dosing. Lapse vaccination schedule, which is a common problem. People start vaccine series and then they don't show up. So what do you do in this situation? You don't have to repeat the vaccine series again. You just do catch up, and you don't have to test to see the response. If anyone you cannot locate their vaccination record, you basically have to treat those patients as unvaccinated. Now I'll talk about vaccine safety and contraindications. Most of the vaccines are safe and causing only minor side effects. The most common problem with vaccine is actually missing the opportunity to vaccinate your patient. Many vaccine causes fever, serum-like sickness, local site injection reaction. These are not contraindication. These are just side effects. Absolute contraindication to vaccination is rare and include hypersensitivity reaction, which is not very common actually to vaccines. And live viruses, vaccines are always obviously contraindicated in immunocompromised. What's not a contraindication? If someone is acutely ill with a febrile illness, if this is a low-grade fever, it's okay to go ahead with the vaccination if you will miss that patient in the future. Current or recent antibiotic use, previous mild reaction, like a localized reaction, that's not a contraindication. Personal history of allergy, not to a specific vaccine, that's not a contraindication. Egg allergy and family history of vaccine to immunization. I'm sorry. Now we'll talk about the immunization schedule for healthy adults. The CDC and ACIP, they review this schedule yearly to include all the newly licensed vaccines. The recommendations are generally varied based on the patient age, prior vaccination history, their health status, their occupation, and travel history also. So this is really the schedule, which is busy. You can see here by age and the recommended vaccines. There is a legend, and this is available in the CDC website. There is an application. I encourage all of you to download it. It's the CDC vaccination application. And basically you go in and you choose a vaccine, tells you all the information you need to know, when to give it and the dosing, the spacing. It also links you to the most updated vaccine. And here, if you go back to adult conditions, it also shows you like which vaccination is recommended in a specific condition. So what changes have happened? So the schedule was updated in October 2022. New changes included the new COVID vaccine, also hepatitis B. There is a new vaccine for hepatitis B. That's also a 3-dose series. And the recommendation for hepatitis B also have changed, that you don't now, the risk factor assessment for Hep B has been removed. The influenza vaccine, also there is update on vaccinated contacts of immunocompromised and the egg allergy. And pneumococcal vaccine also, there is now the PCV 20 and 15, that's not available, unfortunately, in the UAE. And the Zoster vaccine is also, there is update. Now we'll talk about immunization for a special population. Immunocompromised. For the immunocompromised, live vaccines should be deferred until they are no longer immunocompromised. And here the concern is safety, because they don't have the immunity. Those pathogens can reactivate and cause infection. Non-live vaccines may be deferred, but can be given, but you just don't know the efficacy of vaccine. If you end up giving it to someone who is immune deficient, it's reasonable to recheck titers and revaccinate them if needed. The immunocompromised have, it's an independent risk factor for invasive disease, as we know, and also it's one of the indication for pneumococcal vaccine and Haemophilus. Contact of persons with altered immunity, they can get vaccinated for all live attenuated or non-live vaccines, with the exception of smallpox. So there is no restriction. Pregnant ladies. Pregnant ladies, as we know, vaccination in the mother protects both the mom and the fetus, the unborn infant. The immunogenicity, all the immunoglobulins are transferred to the fetus. It reaches 50% of the maternal level by 28 weeks of gestation, and it reaches and it equals it by 36, and by birth usually it exceeds the maternal level. Vaccine safety during pregnancy, depending on the vaccine type and also the trimester, both. So all types of immunization of live vaccine are generally, you should avoid it. It's not contraindicated. Otherwise, the toxoids, inactivated, and immunoglobulins, they're all safe, even the first trimester. But as a rule of thumb, if you don't have to vaccinate the mom in the first trimester, usually you wait until the second trimester or later, where the risk for the infant is lower. Routine vaccination recommended for pregnant ladies are Tdap and yearly influenza vaccine. Immunization to avoid for pregnant, HPV. It's not indicated, it's actually contraindicated to administer to pregnant. But if you start the series and you realize that the female is pregnant, you just wait and complete after they had the baby. MMR, you check titers. If they're not immune, you don't really give them a dose because it contains a live attenuated virus. And you wait for postpartum, but you do vaccinate them before they leave. Varicella, the same thing. There is a new RSV vaccine that's approved by the FDA in August 2023. It's a one dose to protect against invasive disease in infants, but it's not being endorsed by anybody yet. There is also GPS and CMV under investigation. Healthcare workers. So we all really need to be vaccinated and pay attention to our, vaccine records. So what vaccines are recommended for healthcare workers? COVID-19. And this should follow the most recent CDC recommendations for all healthcare workers. Hepatitis B, all healthcare workers should have proof of immunity. If they don't have, they should receive the full series. If their job is very high risk, like phlebotomist, microbiologist, or someone or dialysis nurses, you should obtain serology in those healthcare workers to make sure that they mount an immune response. Annual influenza vaccine is recommended. MMR depends on the year of birth. If they are born after 1957, they should receive 2 doses. Before 1957, they receive 1 dose. Varicella, also you need proof of immunity. If not, they should receive 2 doses for 4 weeks apart. DTaP, all healthcare workers should receive a booster dose, and that should be repeated every 10 years. And meningococcal vaccine is mainly recommended for microbiologists and people who handle the specimens. Now I'll talk about immunization in people with impaired spleen function, both anatomical and functional asplenia. As we know, this puts patient at high risk for severe and lethal infections from encapsulated organisms, from parasites and infections in general. Recommended vaccination for these people are all the vaccines for encapsulated organisms. The strep, the preferred is PCV20, but we don't have it here. So we use PCV13 followed by polysaccharides. So depending on the category, the vaccines is recommended. If they have received both PCV and the polysaccharides, no further vaccination. If they have received PCV13, you wait 8 weeks, you give them polysaccharides. If they have received the polysaccharides, you wait 1 year and you give them the PCV13. Other vaccines, Haemophilus, Neisseria, the 2 types, both the quadrivalent and monovalent, and all the routine vaccination and COVID and annual influenza. When should you give it? As soon as you know that the patient have functional asplenia or anatomical, you should start the vaccination series. But if you know this is someone who is going to have planned splenectomy, you start the vaccine series at least 10 weeks before the surgery. and with the goal to finish 14 days prior to surgery. If that's not possible, then you wait for 2 weeks after the splenectomy and you start the vaccination. If someone after splenectomy, they will be on chemotherapy or immunosuppressive therapy, you wait until they are done, 3 months, then vaccinate them. For those with emergency splenectomy, you wait again the 2 weeks. But if the vaccine series has been started, they have to be revaccinated. Now I'll talk about some selected vaccines, the rationale for their use, risks, and benefits. Let's start with COVID. COVID, as we know, there are so many vaccines licensed so far for COVID, and there are hundreds of trials for new vaccines ongoing. But the most widely accepted now worldwide are the messenger RNA vaccines, and there are 2 types, the Moderna, Pfizer, that's outside the US. The recommendation for COVID-19 vaccination, anyone who is 6 months or older should receive the COVID vaccine. There is an updated messenger RNA formula. It's a bivalent. It's 23-24 formula. It includes all the new, the Omicron and the other resistant variants. So the vaccine basically depends on what the patient, what you should recommend for your patient depends on what they have gotten in the past. Anyone who's younger than 65 and they have received a monovalent vaccine in the past, they're recommended to receive 1 dose of their updated bivalent. Those who are 12 to 64 and have received bivalent, that's it, they don't need more vaccination. Older than 65, they need to be vaccinated regardless of their prior vaccination history. Now, I'll talk about vaccination in moderate or severe immunocompromised. And the definition is basically anyone who is on active treatment for solid or hematological malignancies. People with hematological malignancies, regardless of their therapy, they're considered severe immunocompromised, and CAR-T recipient and some medications. For those people, the recommendation will depend on their prior vaccination status. If they haven't been vaccinated, the recommended is Pfizer here or Moderna, if it's available, 3 doses. If they have received 1 dose, so basically the series is 3 doses. If they have, depending on the number of doses they received in the past, you complete it to reach 3. If they have received all the 3 doses, then they should give them 1 dose of the bivalent. It's recommended if they have received 1 bivalent dose, give them a second one. Contraindication and timing for COVID vaccine in relation to immunosuppression. Those who are planned for hematopoietic stem cell transplant or CAR-T therapy, you should try to give it before, but if you can, you wait at least 3 months after they are no longer immunosuppressed and vaccinate them. Also, anyone who is receiving B-cell depleted therapy like rituximab should be considered for revaccination, and that should be 6 months after completing their therapy. Whenever you have a planned immunosuppression, you should administer your vaccine first, 2 to 4 weeks before. And people who are receiving like ongoing B-cell depletion therapy, like multiple sclerosis patients, rheumatoid arthritis, those you give them the vaccine 4 weeks before the therapy. Antibody testing is not recommended. So contraindication for COVID vaccine. So if someone developed as we know by now, I think most people know that messenger vaccines, messenger RNA vaccines, put some people, they associated with the risk of myocarditis in specific age group, the 12 to 39, and mainly in males. So what you do, this is not a contraindication. You just educate your patient about the symptoms and signs and when to seek medical care. If someone had a COVID vaccine before and developed myocarditis or pericarditis within 3 weeks after the vaccination, that's considered a precaution. It's actually not a contraindication. If it has been more than 3 weeks, then we consider it related to the vaccine. History of heart disease, congenital heart disease, Kawasaki, or ischemic heart disease is not contraindication. COVID vaccination, someone who you think they may be infected, it's not recommended to screen symptom signs or testing before you give the vaccine. But if someone who is symptomatic, you give them the vaccine after they are no longer symptomatic. If they have confirmed COVID, seriously, 20 minutes. Okay. Yeah. So I'll skip the influenza because Dr. Tamina will talk about it. Pneumococcal. Pneumococcal, we have two vaccines, conjugated and polysaccharides. The conjugated vaccine is what's recommended, PCV20, that's not available. So we use the polysaccharides and the Provenor 13. I guess who's at increased risk? Cochlear implants, alcoholics, smokers, asplenic and immunocompromised patients. I showed you that video so you guys can go back to the schedule because I just want to go through. Hepatitis B, this is important. We have changes in the recommendation. Hepatitis B is recommended for all adults who are have risk factor. And now it's a universal vaccination for anyone who is less than 60, regardless of their risk factor. So it's this is a new update. And those who are more than 60 with the risk factor, you vaccinate. If they don't have a risk factor, you can vaccinate. In general, anyone asking to be vaccinated for any vaccine, just give it to them. Hepatitis B is one of the vaccines that you need to screen your patients before actually vaccinating them. And in certain categories, like the dialysis patient and the immunocompromised, you have to recheck for immune response 1 to 2 months later, which is defined as more than 10 unit. If they are not didn't mount an immune response, you repeat the vaccination dose or with a different vaccine or double dose. Zoster, you'll talk about it. So let's skip that. So this is, I think, the important things. So barrier to adult vaccination. The thing, all the studies, they found that most adults will take the vaccines. This I will just have. Can I just continue here without looking at my slide? So most of your patients, they will take the vaccine if it's recommended by a physician. The biggest barrier to vaccination is really vaccine hesitancy. Most people, they are not sure if they need the vaccine, the side effects, the interactions. So I would say, like, all your patients need to hear from you clearly that they need the vaccine, like age-appropriate vaccination in a language that they can understand, and you have to answer their questions and just encourage them to get it. Thank you.